So I'm Nicola Waters, and I'm going to be moderating this session. I'll introduce both speakers now. What we're going to do is have both speakers give their presentations, and then they've opted to have a sort of panel discussion at the end. So if you can save questions after the first presentation, then we'll answer questions on both at the end. So the first speaker today is Dr. Michelle Ray. Dr. Ray is the Associate Director, Guideline Development at RNAO. Dr. Ray oversees the research and evidence development teams who conduct systematic reviews of the academic literature and the methodology for guideline development. In addition, she's leading the development of RNAO's patient and public engagement strategy. Dr. Ray has held many leadership positions at Cancer Care Ontario, the Ivy International Centre for Health Innovation at Western University, and Health Quality Ontario. She has a PhD in medical genetics from the University of Toronto and Master and Bachelor of Science degrees in biochemistry from Queen's University. And the second speaker is Catherine Harley. Catherine is the current Executive Director of the Canadian Association for Enterostomal Therapy, CAET. She's held leadership board positions that have included the Operating Room Nurses Association of Canada Wound Care Alliance, as well as an advisor for the startup of the CAWC. Kathy's past career experience has included serving as the Director of Global Strategic Marketing for the wound care business of Convatec in New Jersey. Additionally, she was Business Unit Manager for Wound and Skin Care Division of Convatec Canada. Kathy is a registered nurse with a neurosurgical ICU clinical background. She completed the International Interdisciplinary Wound Care course at the University of Toronto before graduating with an executive MBA in the US. Kathy also completed a postgraduate certificate in not-for-profit board governance at Telfer School of Business, University of Ottawa. Thanks.
There we go, and thank you, Nicola, for the warm introduction, and thank you to the conference presenters for asking me to speak. As noted in my introduction, I am the Associate Director for Guideline Development, but I'm actually not here today to talk about guideline development. I was asked to give a presentation based on some of the work I had done previously, looking at a review on drug funding sustainability in Ontario and Canada, and some comparisons to other jurisdictions, other countries that are like Canada, but not exactly the same. And as well, I've been doing a lot of work on funding for offloading devices with CLARC and other organizations, and so I think that was the rationale behind, or at least I hope that was the rationale behind why they asked me to give this presentation, and they gave me a lovely title to work with as well. I was like, whose pocket can you pick? That's a really interesting thought, and as I was thinking about this presentation, I'm like, what would I say about that based upon some of the work that I've done thus far? So I don't have any interest to declare. I'm not affiliated with any organizations, and the opinions expressed are my own. So the objectives today for this discussion is really just to go over the reimbursement process that leads to the decision as to whether a particular technology or drug or medical device can be funded, and compare and contrast with some of the other jurisdictions. Specifically, I'll be speaking about Australia and Germany as two particular countries. And then look at what the opportunities are for reimbursement processes and whose pocket can we actually pick when thinking about a technology that should be funded in Ontario or in other provinces in Canada. And I'd like to do that through a case study, which I'll call a tale of two offloading devices, which I'd like for each of you to think about as we go through that and building upon what we know about the reimbursement decision-making process in Ontario and Canada. So first we'll start with what is a medical device or a health product, and I figured it would be best just to use the legal lingo as used by Canada Drugs and Food Act, which says any item that's sold to diagnose, treat, mitigate, or prevent a disease, disorder, or abnormal physical state, or any of their symptoms, including contraceptive devices, and it goes on with a particular list. So really it's pretty much anything related to healthcare that could potentially be supporting patient care, supporting better quality of care, whether it be a cure or whether it be sustaining from a chronic disease management perspective, really anything that comes into Canada goes through this process with Health Canada. And when you look at it from the perspective of having the idea or an initiative or a thought as to what a particular device could be, there's a life cycle for that particular process that starts with the research for that particular great idea that has come forward from either the industry or from research. And they go through a product development and then go through regulatory approval. Then there's clinical acceptance, which is really, does this really make sense? Does this really matter for the patients that are in my care? And then reimbursement, and then marketing of that particular technology. But I thought it really breaks it down for our purposes today, and really for the general public to think about, well, we have all these great ideas, there's a lot of information out there, there's a lot of great devices and drugs and technologies, but from our perspective, really it's number one, getting it approved, and then getting coverage for it. And then if there's no coverage, then we do have to think about our insurance and whether it will be reimbursed for that particular product. So that was what I thought would be a great way of thinking about what the reimbursement process is, to be able to think about whose pocket should we be picking at each of these particular 3 steps. But when you look at Canada, it's a little bit more complicated than that. So we start with Health Canada, which gives that approval for that particular technology. And then it goes to CADTH, which is the, I'm sorry, I'm trying to de-acronymize my life. I'm sure in healthcare there's many acronyms, but CADTH is the Canadian Association for Drugs and Technology Health Services, I hope. And this is sort of the Medical Devices Bureau, where they look at all the drugs and technologies that are brought forward that have been approved for sale by Health Canada. And then at that national level, we then go to the next stage of provincial accessing that particular technology. So we have our provincial ministries, which will then have their own processes and frameworks to be able to identify whether this particular drug, technology, or medical device should be available and should be funded, reimbursed within the province. And in Ontario, it's OTAC, which is the Ontario Health Technology Assessments Committee. And then in some situations, you see the dashed line, it even goes further than that. So sometimes regional health authorities may then decide, well, for this particular region, we want to look at our own assessment to see whether this makes sense for our LHIN, our Local Health Integration Network, or our regional health authority in BC, as they're called. And then even to the next level, where sometimes a hospital itself may say, should I be taking this money from my budget to fund for this particular device, for surgery or others? And so they may in fact do their own assessment at the hospital level. So that can take some time, as you can imagine, from the time of approval down here to the time it gets to the patient who needs this particular device to be able to support their care. So I thought when you look at it from this a Canadian perspective, really all these different health authorities in the country that we have for 35 million people, you can imagine the variety and variance between one province to another province, and even one regional health authority to another regional health authority within a province. And that's part of the challenge that we do have in Canada, is this variation. I thought we'd take a look at Australia. It's approximately the same size population-wise. Geographically, obviously, it's much smaller, but 23 million compared to our 30-plus million. They do have regional health authorities. They have 6, much less than what we have here in Canada. And they have a similar process. So there's a protocol that's been created by the particular company that's created this particular device. And then they go through a committee that consisting of health experts and public and stakeholder consultation. And they together then create their own protocol, which is then submitted to HTA analysis by these subcommittees. So these subcommittees will be particular to different diseases, different types of technologies, different types of drugs. And then that subcommittee then goes to the Medical Advisory Committee, which makes that final recommendation to the Minister of Health. And then once that Minister of Health has decided, yes, this is approved and this will be funded, that then affects all 6 of those regional health authorities in the province and in the country. So there's no regional variation across Australia for those particular devices. You might say that Australia is much smaller, or it's down under, as it's called. So I thought perhaps we'll take another look at another country. So how about Germany, which is 80 million people, so more than twice the size of Canada. They do have regional health authorities as well, but they operate slightly different. So when an application is made, can't see my pointer. So an application is made by a particular particular industry. They've come up with a novel idea, a new medical device. It goes to what they call the Federal Joint Committee. And this committee is comprised of a multitude of different stakeholders, including the hospitals, the clinicians, even the patient organizations, and they decide whether this application is even worth considering for HTA analysis. If it is, then this Institute for Quality and Efficiency in Healthcare, which is one expert committee group, will then go forward with a recommendation back to this group as to whether this particular technology or device should be funded. And if so, that group then gives a directive to the minister to be able to provide this for all 80 million people in the country. And now it will go through different approval processes for different ways it can be funded, whether it be through hospital, through health funds, through insurance. But at the end of the day, once that decision is made, all 80 million people will have access to that particular device. So when I say that these groups are like ITQIG and CADIS and HQO are doing their own analyses, what really are they looking at to be able to decide whether this particular technology should be reimbursed? And there's a lot of different decision-making frameworks out there, but looking at across all of them, they tend to have similar ideas as to what should be looked at. They'll look at evidence. So this is the literature, the clinical trial information, the published literature that's out there. They'll look at the quality of that evidence. So was it a strong study? Was it a double or even triple blinded now clinical trial study is the new highest level of quality? They'll look at strength of evidence, which is then looking at, did they look at benefits and harms and patient preferences and other considerations as well. So it's not just whether the particular technology is effective, but is it actually going to be better than what's currently out there, and is it going to be something that clinicians will want to be able to provide to their patients? They look at strength and quality of available economic information, so basically looking at a cost-effectiveness analysis. It's interesting that as part of my work previously, when speaking to ITWIG in Germany, they actually don't do any cost-effective analysis, no cost-benefits, partly because of their historical and cultural approach where they don't want to put any value on human life. So they actually do no cost-effectiveness analysis. It's purely based upon quality of evidence and strength of evidence. These groups will look at current practices and resource utilization patterns, and then other factors such as patient input, ethical, environmental, geographical, all the other considerations will go into that decision-making framework as to whether this particular technology should be reimbursed or not. And this is just an example from CADIS of what their health technology expert review panel, HTERP as they call it, actually looks at. So they'll look at the benefits and harms, patient preferences, economic impact. We'll also look at legal impact as well in some situations, and there's the ethics and environmental. So that's their framework that particular panel uses for any technology that comes forward in Canada. So going back to that original question of whose pocket can you pick, I've talked a lot about these different review panels and how they use this decision-making framework. Now, when you think about it, the federal government does not really make a play as to whether something should be reimbursed or not. They're really just looking at the federal level as to whether something should be approved and be available. So it really comes down to the provincial government to be able to make that decision as to whether something should be reimbursed. The challenge there is that if it isn't, then it does then come back to the insurance to then be able to have that access to the insurance to be able to be reimbursed. But all of those things at the end of the day come back to patients and the public to be able to have their pockets picked, if you will, to be able to have that particular technology available to them. So sometimes evidence and decision making does have that disconnect of patients, and sometimes evidence is just not enough. So perhaps we need to really consider how we can incorporate patients and the public into our evidence decision making process so that we can see the evidence and the experience together because they should both matter when considering reimbursement. And if you'll notice on the Germany model, you'll notice that patient organizations are included on the Federal Joint Committee, but the public actually don't have any voting power. So they're only there as an advisory for that decision as to whether something should be reimbursed or not. So it's a question that we need to think about and how things can move forward. I'm happy to say, though, for CADIS, the HTERP consists of 5 core members. And those core members include people with qualifications in evidence-based medicine or critical appraisal. They have a chair, an ethicist, a health economist, a healthcare practitioner, and one public member. And those core members sit on every advisory panel, in addition to the specialists based upon the particular technology. So it's good to know that at least there is one public member or patient member who will be sitting on those panels and having those discussions about what the values and preferences may be from a patient perspective. This was just released just a few months ago, in fact, where OTAC has partnered with Julia Abelson, who is a researcher at McMaster in patient and public engagement. And together they've come up with a framework of how to incorporate patient and public involvement into their HTA analyses. And I won't go into detail, but basically they have the different steps of topic selection, scoping, evidence-based analysis, assessment of comments and peer review, and then what they've outlined here is how they've incorporated patients and the public into each one of those stages. And they've separated that group out of whether it should be a general public, or should it be a patient, or should it be a patient organization who's advocating for a particular technology. And this is the framework that they're using now for all of their technologies moving forward. So it seems that having the experience and the evidence does lead to a stronger decision-making framework for a reimbursement as to whose pocket should we be picking. And I'd like to end off with just a brief case study, if you will, to think about whose pocket are we picking with a tale of two offloading devices. Now, many of you are familiar with diabetic foot ulcers, given the topic of our conference, but 11 million Canadians have diabetes, and 40 times more will develop wounds than the general population. As you know, these foot ulcers often lead to infections, and that can ultimately lead to the amputation of the foot. And every 4 hours in Ontario, somebody has their foot removed because of a diabetic foot ulcer. And worse, once having that amputation, it actually leads to even worse health outcomes, including death. It's something that having your foot amputated leads to a higher risk of mortality. So for the person and the system, there's clearly a need to have both a preventive measure in place and an opportunity to be able to have support for when there is an ulcer to reduce the risk of having that amputation. It's obviously very effective from a costing perspective, 5 days in the hospital versus 86 days in the hospital if you have an amputation. So from a cost perspective to the system, that's really important, but you can imagine from the patient perspective as well. And there's lots of evidence to say that the reduction of pressure on the diabetic foot ulcer, on the wound, can be supported through the use of an offloading device. And there's different offloading devices out there, but some of the most frequently used are the total contact cast and the removable cast walker. And as of late, the irremovable cast walker, which is called the instant total contact cast. And I'd just like to give a summary of some of the work that has been done thus far in the province of Ontario, looking at these three different types of offloading devices. And really, I'm grouping these two together because these two are the same. The instant total contact cast is really just something as simple as duct tape, as some people have used, to be able to render it irremovable. But when you look at pressure reduction, which is the ultimate goal of the offloading device, all three of these have been proven to be equally effective. You look at healing time, the total contact cast is pretty the gold standard because it does reduce the healing time. But most of that is because of the ease of is because of the fact that it cannot be removed, and so the patient doesn't have the opportunity to take off the cast and can reduce the healing time for that reason. That's why when rendering the removable cast walker irremovable, by use of any kind of string or tape or anything like that, it actually then decreases the healing time to be similar to the total contact cast. The ease of application, obviously to have a total contact cast applied, it does have to be, you have to go to a specialist to have that applied, and you have to go to that particular location, as opposed to, a number of different healthcare providers are able to put on a removable cast walker and instruct patients on how to be able to use it. The indications, if the ulcer is infected, you actually cannot put a total contact cast on, and this is actually quite common for people with diabetic foot ulcers, is to have an infection. With the removable cast walker and the rendered irremovable, the clinician can remove that to be able to look at the infection to see if it's progressing, apply any topical ointments as necessary. And then, of course, patient preference. Patients prefer to be able to have the cast removed as necessary for whether it be for bathing or for or even for work purposes. And then cost. The cost of the total contact cast is about $1,000 or more, compared to about $100 for the irremovable contact cast. So with that, I was going to leave it open for discussion after we hear from Catherine about some of her work as well.
Thank you, Michelle. Very interesting. And I'm going to springboard off Michelle's presentation this morning. I have no conflict of interest. And what I'm going to do in the short time that we have together is start with a quick high-level view of what is happening with the cash flow at the federal and provincial government level. I'm going to take you from there into how is that impacting clinical decision-making, and what are some of the things that you need to be aware of as you are in the clinical setting and having to make decisions based on cost effectiveness or cost efficiency. I'm then going to give you the most current update on the Canada Health Accord and finish up with some strategies as to how you can navigate that in your clinical setting. And so the Liberals came in a year ago and they've made a promise. And one of the promises was real change for the middle class. And so, of course, that involves money. And so Canada right now is facing an important next step in Medicare history. So how many of you are aware that the current health accord expired in 2014? How many of you are aware of that? Okay. There was a national poll done across Canada by Canada 2020, which is an Ottawa think tank. And they said that less than 15% of Canadians are aware that there is no health accord in place currently, that it's expired. So our publicly funded universal healthcare system is a source of pride for all Canadians, and it does give us some economic security, especially for the middle class, where the Liberal government focus is, and for those who are trying to get into the middle class. And the Liberal government does believe that if Canadians are in good health, that they will be able to contribute more fully to the overall economic picture in Canada. So they really want to focus on healthcare and getting a good healthcare program into place. But there is a controversy. And the healthcare system has been in the middle of a controversy because the efficiencies of the current system just aren't there to deliver treatments. How many of you agree with that? Do you think our current system is efficient the way it is right now? Okay. There's also worries about privatization. So there's worry that the privatization will start to increase and that only wealthy people will be able to afford health care as we move forward. So they're looking at all of these angles and they're trying to come up with a model that will be most effective for the Canadian population. And so one point I want to get across is that there is no single national healthcare system in Canada. We have a 14 single-payer universal and public health system that includes 10 provinces, 3 territories, and the federal government, who is focusing on health services to select populations with First Nations, Veterans Affairs, military personnel, and inmates in federal prisons. And so when you pull all of these things together, collectively you have Medicare. And just so that you're aware, and I always think it's important that you know where healthcare money comes from, the financing of healthcare is provided through taxation, so it comes from both your personal income tax and it comes from corporate income tax. Some provinces have additional funds that they inject into their provincial healthcare systems through sales tax and lotteries. And then there are 3 provinces, Alberta, BC, and Ontario, that charge health premiums to supplement their health funding. But at a federal level, the funds are allocated to the provinces through what's called a Canadian Health and Social Service Transfer, and the short form is CHST plus cash contribution. So you're getting the transfer of a percentage of healthcare spending from the feds into the provinces, and then you're getting a lump sum injection that is spread across the provinces. So those are two ways that the funding flows. So bottom line is that Canada spends more than $200 billion on healthcare a year, but there is a challenge of controlling the costs and establishing sustainability. And to be frank, sometimes I don't think they know if the healthcare money at the provincial level that's being transferred is actually being spent on healthcare. And I know that's something that is being looked into. And the total financial picture is also compounded by the social determinants of health, with technology changing, with a growth of an aging population, and a rise in multiple chronic conditions as our population is aging. And so I'm not going to get into a lot of detail. You can see the economics there, but we've got a 70-30 split public-private. The provinces are spending roughly 40% on healthcare. And in 2004, the federal government was actually transferring 6% for a 10-year period, which expired in 2014, as I mentioned. And so before the Conservative government went out, they actually gave a 3-year extension while promising future annual increases of only 3%. So it's actually a drop. And we're going to talk about that a bit later in the presentation when I give you an update on where the health accord is at. And then the other thing we're hearing, how many of you are hearing this? We're going to shift from the hospital to the community. Everything's going to move, but where's the funding to support it? And so, we know people want to receive care at home, and we've got this aging population. We've got better access to technology. But overall, I think the government perceives that it is less expensive to keep people in their homes and that it is lower cost care. But is there the right model to sustain this type of system? And so what ends up happening is that you have a cyclical funding. And so the government is, they're putting out their mandates and they're choosing the types of services that they're going to put out into the healthcare sector, the delivery models. But if they change their agenda or they change the people representing the portfolio, it is vulnerable to ups and downs in cyclical funding, and it also is impacted on any political change that can happen. So it's really important as healthcare professionals that you really stay knowledgeable and vigilant about what's happening with healthcare in your area, in your local area, your region, your province, and even federally. Get the newspaper, read what's happening, because these changes can definitely trickle down over time and impact you in the clinical setting. So this is our reality. Everyone agrees to help reduce healthcare costs, but the bottom line is people can't afford their diagnosis in a lot of cases. And so let's talk for a minute about securing funding for wound management. So this is really challenging, not just in Canada, but in many countries around the world, because the bottom line is that wound care isn't recognized as a distinct field. And because of that, funding doesn't always get allocated to a wound care portfolio. How many of you would agree with that? Yeah. And so I think that's why with CAWC and CAET and RNAO and CNA and other not-for-profit organizations are really working hard to build this area. And this is the economic reality. So gaining funding for wound care, it does involve a level of competition. You have to have leaders that are going to go out there and advocate to get their share, to get their piece of the pie of this funding, because you're up against other disease states that are also going after the funding. And the bottom line is that if you're going after wound care funding, you have to be able to demonstrate the value for money, and you have to have data. We must have outcomes data to show that the treatment modality or the protocol that you're using in your clinical setting is valid and effective. And also, you need to necessitate detailing the costs using the modality or protocol as well. So this is our economic reality. So I did some of the economics of wound care in Canada, and the most recent data that I've seen, it's just under $4 billion in spend. It's about 3% of the total healthcare costs. Diabetic foot ulcers are costly. Cost to treat venous ulcers, very high. And diabetes and diabetic foot wounds, a large cost to the healthcare system. And if any of you are interested in getting these statistics after you want a copy, I'm more than happy to share this with you. We also know that up to 50% of all Canadian healthcare involves a wound of some sort, that 50% of the nursing visits in the community involve wound care, and that 25% of people that are in an acute care setting will have some level of pressure injury. And so CIHI, the Canadian Institute for Health Information, in 2013, under Dr. Keith Denny, did a study on compromised wounds in Canada. And what he found was that the wounds are underreported, particularly in inpatient settings. And also, they found that the wounds in early stages weren't properly identified or captured in administrative records, and overall there was an underreporting in the prevalence of wounds in the acute care setting. So after I read this study and looked at the data, my question back is, well, do we really even know what the cost of wound care in Canada is? And so the other thing when you're looking at the cost of wound care is that you need to look at the social determinants of health. So look, when we're talking about the social determinants of health, we know that poverty is a greater risk factor in diabetes than diet or exercise. We know that Canadians with annual incomes under $30,000 are at least twice as likely to contract diabetes as those with income over $80,000. We also know that research estimates that 1 in 10 hospital admissions in Canada are due to diabetes and its complications, which is quite high. And that the CDA in Canada tallied that healthcare costs were over $13 billion a year. The other thing, and this has been mandated at every level of the federal and provincial governments, is a focus on the care of the elderly. And I think the take home with this is that by 2050, the proportion of Canada's elderly is estimated to be 1 in every 4 person. And when you break that down and look at the rising diabetes, the rising chronic disease, we know that we have right now a healthcare system that will not sustain this growth unless there is complete transformation and change. And so when we look at the actual statistics of the wound types, you can see it for yourself on the slide, and I just wanted to really let you know that we know we have all of these chronic wounds and the numbers are high. And when we're looking at the high numbers, the high dollars are attached to them. So we do need to be vigilant to know how many wounds we're dealing with and really what it's costing us to treat them. And so now I'd like to just talk a little bit about the cost-effective, cost-efficiency piece and make sure that in basic terms, when we're talking about cost-effective, it's economical in terms of the tangible benefit produced by the money spent. So it's effective in relationship to the spend or the cost of the product that you're using or the treatment. But the definition of cost efficiency, think of it as productivity. So you're saving money by using that product better, maybe making sure that you have the proper wear time, making sure that you have a product that has the right absorption for the level of exudate that you're dealing with. And the other thing that we're looking at in cost efficiency is around wastage of resources. So I think wastage, how many of you on a daily basis would say that you see wound care products or supplies being wasted within your organization? And you think of that, and if there was just, a project that someone could lead on reducing the wastage and some way that you could frame that up, that starts changing the system. So that's something that is really important to look at, particularly in the community. It's a big, big issue. The other thing I wanted to make sure that everybody was clear on are the direct costs and the indirect costs. So the direct costs, of course, are all the costs that are incurred by the health system or the patient as a direct result of the disease. For example, the pressure ulcer and everything else that's around the pressure ulcer and the costs that are attributed to the entire case would be a direct cost. But there are so many indirect costs, and they're less obvious. And if somebody can't go back to work and they end up having to go on Social Security, or they end up having to, take insurance claims or other areas, this is impacting the economy. So we really do need to look at the big picture when we're looking at the economy. And then the other area around the money is the value for money. And has your organization received maximum benefit from the treatments and the protocol of care that you have implemented into your organization? And do you have enough resources to do it? How many of you have enough resources to be able to deliver the care in manpower? Do you have enough resources? No. So that's a big issue. It's not just about products, it's the big picture, it's the all resources. So looking at value for money, sometimes it's subjective and it is hard to measure. And it is based not only on minimum purchase price, but also on the efficiency and effectiveness of what you're using. And so everybody is being asked for cost justification. And you're required to cost justify your decision making to non-clinical managers in many cases. How many of you in the room have a clinical manager who has a nursing background? Show of hands. Okay, how many of you have a clinical manager who has a business background or a non-nursing background? Okay, so there's still a few. So the bottom line is that when you are going through your decision-making process, it's important to look at the benefits, the costs, and support it with robust evidence. And again, that's why conferences like this are good, so that you can get access to the latest research and the evidence to support what you are implementing in your clinical practice. And so what factors are affecting cost effectiveness in wound care clinical decision making? Well, the first thing is everybody is under pressure. They're under pressure to be cost effective in what they're doing as far as clinical care. And really right now, I would say people need to be able to get the skills to accurately look at the costs and be able to communicate that to their management. So if you put somebody into, say, a more expensive treatment, but their healing time is shorter, or you've reduced a hospital admission, or you've been able to prevent infection, all of that has an economic benefit that needs to be considered. And those who are monitoring and overseeing budgets, so if any of you are in a management position, you really need to have a bigger picture of the global cost of the care provision because the structures are disjointed, and there needs to be somebody who is keeping an eye on this and communicating it. And I know especially when the patient moves out of the hospital, the silos come up, and it's very important that this is communicated. And so there have been studies done around practice-based knowledge being a major influence on clinical decision-making, but also that the personal experience and opinion of colleagues continues to impact clinical decision-making. And sometimes it does put people into a smaller range of options because, they're comfortable with what they've had good results with in the past. So sometimes it's good to really reach out and update and make sure that you are looking at other options that are cost effective. And you can see, and as Michelle mentioned, there are different frameworks for decision making. There's frameworks for clinical decision making. I think that it's really important that you agree with the patient, you set mutual goals with the patient to work towards patient adherence, because that also contributes to the cost outcome. But the bottom line is it has to be evaluated. I had a former colleague tell me about 2 years ago that she was called into an organization in the community in Ontario. And after spending $10,000 on compression before the wound specialist was brought in, the patient actually had an arterial ulcer and was in totally the wrong treatment. So to me, it really, who was tracking the outcomes and really making sure there was a thorough assessment done. And then we have the economic impact. And so this is really around people, if they have a lack of knowledge in appropriate treatment choices and the inability to correctly value the importance of the clinical information presented. So again, this really goes back to assessment is crucial and making sure that you are using evidence-based decision-making. And then the last piece around this decision-making is around non-clinical influences on decision-making. So again, we go back to the social determinants of health and that whole piece around patient adherence, and particularly in diabetic foot patients with offloading devices and patients in compression. And really, you have to keep an eye on all of these factors. And now with patient family caregivers increasing in numbers with the aging population, they need to be brought into the loop right up front and be part of this team. And so there are things that you as wound care clinicians can do every day to focus on reducing the costs of care. And it really starts at the patient level, at the clinical setting. And I think the whole area around prevention really needs a strong focus, because if we prevent the skin from breaking down to begin with, this shouldn't happen. I had an experience a couple of weeks ago with a family member who was admitted to hospital, who after a week got a reddened coccyx, and I did talk to the nurse, and this was in a major teaching hospital, about it, and she said, yes, I knew about that, and I actually brought it up at my team meeting, and so everybody's aware of it. And I said, well, that's great that you brought it up, but what are you doing about it? Like, what are the preventative measures that are being put into place? Well, we haven't got to that yet, but we're having another meeting tomorrow, and so then we'll talk about it, and we'll see whether or not we need to bring the occupational therapist in. And I said, tomorrow's too late. So this is just, sometimes we just have to really make sure that people are focused on prevention and keep statistics and track outcomes. The other question is new versus traditional. And again, it's looking at newer technologies, and while they may be more expensive, if they are getting people out into the community faster, and if they're supporting care outside the hospital, reducing emerge visits and reducing time to heal, we need to be looking at newer options. And then kind of moving toward wrapping this section up, collecting accurate data in wound management is difficult. How many of you would agree with that, the data collection? So it's sporadic, it can be inconsistent, it can make meta-analysis very difficult if it's not done appropriately. And overall, the data that we have is either non-existing or lacking. There are outcomes measurement companies that are now available in Canada, and so it's very important to look within your organizations and ask, how are you tracking the wound outcomes, and how are you documenting them, and how are you looking at the global or the bigger picture within your facility. And then wound outcomes measures. So this is really all about looking at the wound type, patient condition, and intervention being studied. It should be meaningful to patients. And I just put a list here of some of the outcome measures used in wound care. And I noticed Ron Shannon come into the room. And if any of you want to see someone who's very good at setting up wound outcomes measurement, Ron is definitely one of the leading experts in that area. So best practice and expertise saves dollars, and I just put one study here, but there are many studies available to say that if you have a wound specialist involved in care directly or in a consultative capacity, you will see significant improvements in wound care. I already touched on the importance of patient adherence. This is critical in creating a cost effective and efficient system within your organization. And I just wanted to mention this study. It was done in the US by Carolyn Fife et al., published in Wounds in 2012. And what they did was they analyzed wound outcomes and cost using a wound registry and an outcomes database. They had 5,240 patients with 7,099 wounds. And I found this study an excellent example of analyzing outcomes in a practice that can support decision-making and improve economic value of wound care interventions for patients. And in this study, I also wanted to point out a key finding, and this comes up in discussions with management and getting funding for wound care, and it's around all wounds will not heal. While most people are focused on complete closure, this study clearly showed that non-healing wounds were among the most expensive, and they even found that the non-healing patients' cost of care increased in a near linear fashion, and that what they did was look at putting patients into appropriate treatments, and the cost savings may not be visible in those treatments, but they may be visible in reduction of hospital admissions and other things. So you really need to think out of the box when you're working with non-healing or palliative wounds. And we all know that it's important to have a wound data management system that you can track the statistics. How many of you right now in your organizations have wound tracking systems? How many do not? How many do not? So there's a lot of room to grow in that area. Okay, and then benchmarking, and I'm just mentioning that, and I think Michelle had kind of touched on benchmarking, but know how what you're doing in your practice compares to what someone else is doing in their practice, and this is also to see if you measure up. And accountability. We have to be accountable for the dollars spent. Everybody plays a role in it, and the gold standard is not always operationally feasible. And so I'm just going to finish up. I only have 1 minute. This is a lot of information to put into a small time. But the Health Accord, there was a meeting in Ottawa, September 29th. They brought all the decision makers in and the health ministers. And there was conflict between the federal government and the provincial government. So the Fed said, we're giving 3% in cash injections. The Quebec health minister got up and said, you're not even going to meet our rate of inflation, let alone keep the lights on in the hospital. And so they really came to a stalemate. And so the results of the meeting is that there is agreement on the 5 areas: home care, mental health, Indigenous innovation, and pharmacare, but they didn't agree on that 3% transfer, and so they have not renegotiated the new health accord. And I just did the math, and the Ontario, it would be 400 million would be taken out of the system and 1 billion nationally if they reduce the transfer by the 3%. And so the feds have committed an additional $3 billion over 4 years to improve home care in a separate cash injection, but that is across all of those 14 jurisdictions. So actually 13, because that wouldn't include the feds. So I'm just going to move on to the ending. So anyway, just to let you know, the next step, there is a meeting in December between the premiers and the Prime Minister, and they say that the health accord will be on that agenda, so that's coming up. And so just to finish, what do you need to do to navigate this health system and to ensure that you can be a part of this? We may not see wound care listed in these priorities, so we need to hitch on to one of these or multiple or some of them and get in there and start talking about wound care. We need to prepare for innovation through technology. They're looking at getting rid of paper systems and moving to one streamlined electronic system with patient, caregiver, and facility. They're going to be focusing on performance and efficiency, so you need data collection within your organization. There'll be more efforts and focus on resource allocation and health systems planning to make sure future needs of organizations are met. They'll continue to work on access to wait times, and everything is shifting to patient-centered care and the 8 dimensions of patient focus. So to finish, my last key learning points are the financial constraints in wound care are going to become more stringent as the government is struggling. There's a lot of financial pressure right now, and managers and clinicians must have a better understanding of how the money flows and how the decisions they make impact that. You need to think about how to reduce cost and care delivery, but you must maintain the standards of patient care and clinical outcomes. And we need to move away from simplistic unit-based thinking to looking at the global picture. Thank you very much. And Michelle's going to come up and we're going to answer any questions. Yes.
Can't get out of this, but when is there going to be something done about the education of nurses and physicians? Because right now they come out having had leadership courses and all kinds of things like that. They can do a presentation. I just finished my degree after I had been a nurse for many years. They can do a presentation like I cannot believe, but they haven't got a clue about wound care. And a lot of them get hired now. I work at CCAC. A lot of them get hired straight out of school into our agencies. They're alone in a home. And by the way the agencies pay, at least at my CCAC, is by the visit. According to us, a visit can take up to 2 hours. There is no way any of them spend anywhere near that time. So a bunch of different things here going on in my head, but you know, there's no accountability, there's no education. Like this stuff needs to change, or this won't change.
Like I can add to that comment, like I spoke at Trent University, I'm an interostomol therapist, so I spoke to the nursing students, their 3rd-year course, and I was given a 2-hour time slot to teach about wounds and products. That was it. That was their wound care education in there.
In 4 years.
Yep. That was it. And that was just last year, so that's recent.
You can't. Yeah, so I think to summarize, you're saying that people are coming out of education courses, but they don't have the practical experience on wounds, and then they're going into situations that they're not equipped to be able to handle.
That's right, and there's no accountability there either.
Yeah, and they're not being held accountable. And then she was saying that she was given 2 hours to present on wound care to nursing students. And I think that really around that, it's working towards system change. And so we need leadership to step up. We need leaders to be developed. And if sometimes people say, well, I'm just at the bedside or I'm just going in to see the patient, but everybody has the capacity to lead. And so if what you're saying, if you can document and keep track of what's happening and filter that to your manager and really put a focus on how the system, where the gaps are and how things could be improved, is that an option?
Well, I just think the top people in this country need to do something about changing the curriculum. I think that's what it is.
Maybe I should get up and speak to this since I'm the moderator in this group. So I would just like to say for anybody who doesn't know me here, and I am just moderating in here, but I am a professor at Thompson Rivers University of Nursing, and I am presenting on wound care at the Canadian Association of Schools of Nursing, and I'm also at the National Council of Nursing next week in Ottawa, and so these topics are being brought up and we are trying to do something about it, and what we would like to do is collect information from people because, again, we need the data to support what it is that we're trying to do. So please let us know, and if you are interested, I can send my email out or come and catch me, and the more information I can get, the more we can pass on, and there will be changes made.
Yes.
Sorry to hijack your talk.
That's okay.
there.
No.
I think to add to that, I think we need to be engaging our licensing bodies
Yes.
and demanding that they are looking at how clinicians are coming out of school. Because I completely agree with you. They're not coming out, they're coming out knowing how to dress a sterile surgical wound in one setting. And even the amount of practice they get on a surgical wound is minimal. They're not practice ready, and they're certainly not able to cope with the enormity of this condition. You know, when we look at it from a chronic disease management perspective, that's really what we're looking at.
Yes.
If I can comment on something with regards to home care, I think we might want to consider taking a or having a trial in terms of outcomes being for what they are in sort of a visit by visit, or the way the system is currently set up. So nurses are paid per visit versus per outcome met, compared to a nurse who is on staff and maybe is receiving a shift payment and seeing more patients or fewer patients, but doing more education on self-management, on chronic disease management, on wound care management, and so on. So we might trial that and see if there's a difference. Yes, yes. Care planning.
Yeah. How many of you are comfortable in advocating within your own organization? So you're okay. So that's a starting point, because sometimes it's not easy, and sometimes people are afraid to speak up. But we all need to start speaking up, and making sure that people know there has to be a change, but also clearly articulate where the gaps are and what does the change need to look like. Frame it up.
So it sounds like this conversation is going to continue over lunch. So I'd like to thank both the speakers, and please follow them and continue to ask them questions.